Today we are dealing with ischemic heart disease, and it's a very, very important topic we need to deal with. So the first thing we need to understand is when we're talking about ischemic heart disease, we're also talking about, acute coronary syndrome. Okay, acute coronary syndrome. So acute coronary syndrome basically refers to a suspicion or confirmation of acute myocardial ischemia and or infarction. So you're talking about either the blood flow to that part of the heart is decreased, and because of that, the patient's experiencing a lot of chest pain and all that, or there's actually infarction going on. That is what acute coronary syndrome is all about. Now, when you talk about acute coronary syndrome, we're talking about an umbrella term. Okay, we're talking about an umbrella term, and we're talking about three things here. Number one is ST segment elevation myocardial infarction, which we call STEMI. STEMI. Number two, non-ST elevation myocardial infarction, which we call non-STEMI or NSTEMI. And then we also have another nomenclature we call unstable angina. And today I'm going to use this class to help us to break these three topics down very, very well. STEMI, NSTEMI, unstable angina. Three things that we need to know. And let me know in the comment section if you've been struggling with this in the past. If you've been struggling with this in the past, because this is very, very important. STEMI, NSTEMI, and unstable angina. Let me know if you've been struggling with this in the past, because it's a subject that many candidates have told me, Dr. Broni, I've struggled with this. So just let me know. Just let me know whether it's been a struggle for you. And if yes, then let's take our time and break it down today. STEMI, NSTEMI, and unstable angina. Okay. And I'm going to use, some of the latest information we have in the system to teach this particular topic. So there's been a diagnostic shift. When I say there's been a diagnostic shift, what I mean is that, the use of high sensitive troponin tests has changed the way we consider these three nomenclatures: STEMI, NSTEMI, and unstable angina. It's all because of troponin levels. And what do I mean by that? You realize that in the past, historically, unstable angina has always been defined as a patient with ischemic changes, so say chest pain, with ECG changes, but without elevated troponin levels. That's how the definition has been in the past, right? Now, but in today's terms, you realize that almost all patients with ischemic changes and symptoms and ECG changes have elevated troponin level. And whenever you see elevated troponin level, that should tell you that the patient has a myocardial injury. That means the heart muscle is injured. So they are now classified more of NSTEMI and less of unstable angina. And I'm going to take us through some questions so that we can be able to tell the difference. Now, why does the clinical classification matter? And I need you to write this down. Because if you don't distinguish between STEMI and NSTEMI in your board exam, as well as in practice, it will affect the way you manage the patient. What do I mean by that? And this one, I need you to write it in your book right away. Please write it in your book. I'm going to take a pause here. If you like, you can even take a screenshot for your notes. For patients with STEMI, that is ST elevation myocardial infarction, their management is different from the way you manage a patient with NSTEMI. In STEMI, you do what we call emergency reperfusion, where you can do PCI or thrombolysis. And another assignment I want to give you is, please learn the contraindications for thrombolysis. You can't go into any board exam in these days without knowing the contraindications for thrombolysis. You need to know. So let me even take a pause here. Who can type some of the contraindications for thrombolysis for me to see? What are the contraindications for thrombolysis? Please let me know. I was going to give it as an assignment, but let's discuss it. What are the contraindications for thrombolysis? Please type your answers right now. What are the contraindications for thrombolysis? Thrombolizing, breaking down the blood clot. What are the contraindications for thrombolysis? Please type your answers right now. You should be able to type at least 6 answers. So what are the contraindications for thrombolysis? I want to know. What are the contraindications for thrombolysis? Please put in your answers. Head trauma in the last 3 months, okay? What are the contraindications for thrombolysis? I'm waiting for more answers. What are the contraindications for thrombolysis? What are the contraindications for thrombolysis? Okay. So, bleeding disorder, beautiful. AV malformation from Dr. Joanna Cruz. Bleeding disorder from Dr. Ichebi. Allergy to meds. Sure, if you're allergic to a medication, but it's then Dr. Akabueze says recent stroke, bleeding disorders, head trauma in the last 3 months. So if you have a patient with active bleeding, apart from menstrual bleeding, contraindication for thrombolysis, or if you have a patient with bleeding disorder, that's another contraindication for thrombolysis. Okay. And then if you have a patient who has had a recent significant head or facial trauma, another contraindication for thrombolysis, as well as a patient who has had a recent or intracranial or a spinal injury or surgery, that's another contraindication. So I've listed 4 already. And if you have a patient who has had a history of intracranial bleed, another contraindication. Another contraindication that many people forget is a known history of malignant brain tumor. That's another contraindication for thrombolysis. And then structural cerebral vascular lesion, another contraindication. When it comes to the chest, if you have a patient who has a suspected aortic dissection, another contraindication. Okay, another contraindication. And if you have a patient who has had ischemic stroke in the past 3 months, another contraindication. Okay, so these, we have the absolute contraindications and then the relative contraindications. And with the relative contraindications, I've seen that somebody has written something about uncontrolled hypertension and all that. Now, one of the relative contraindications is if you have a patient who is having ongoing anticoagulant therapy, the patient's already on a DOAC like rivaroxaban, apixaban, dabigatran, those kinds of medications. And then if the patient in the last 2 to 4 weeks has had internal bleeding, that's another relative contraindication. And if you also have a patient who has, say, an active peptic ulcer disease, that's another contraindication. And if you have a patient who is currently pregnant or recently became postpartum, another serious contraindication or a relative contraindication. So please, before you leave this class, I need you to, I was going to give it as an assignment, but I was like, let me just bring it up right away. Absolute contraindications. Number 1, active bleeding or bleeding disorders. Number 2, intracranial hemorrhage, cerebral vascular lesions, malignant intracranial neoplasm as well, ischemic stroke in the last 3 months, head trauma or spinal trauma or spinal surgery, suspected aortic dissection where there's a tear in the aorta. Okay, if the patient has severe uncontrolled hypertension, that's another absolute contraindication. Then when it comes to relative contraindications, if the patient has ongoing anticoagulant therapy. Number 2, the patient has had recent internal bleeding, that is 2 to 4 weeks ago, active peptic ulcer disease, and a patient who has been pregnant or who is currently pregnant or recently been in the postpartum state. So I hope this helps very well. I hope this helps. So I'm going to move on. Can I move on to the next slide? I just want to know. Can I move on to the next slide? Can I move on to the next slide? Okay, good. Because this is something you can't miss. You are going to a board exam. You need to know it. You need to know it. You are going into a board exam. You need to know it. So this is what I was talking about. You need to know the difference between STEMI and NSTEMI. Why? Because of the way they are managed. So in your board exam, always remember that STEMI is managed a bit different from NSTEMI. With NSTEMI, you manage it with risk stratification and early invasive evaluation. So let's keep it very simple. What is STEMI? What is STEMI? STEMI, the name gives it out. ST elevation on ECG, which is pointing to the fact that the patient's vessel, that vessel which has been affected, is completely blocked. And NSTEMI is a non-ST segment elevation, which also leads to elevated troponin level. Okay, elevated troponin level. So now let's do some questions. Let's deal with a question. You have a 58-year-old man who presents with chest pain and ST depression on ECG. His high sensitive troponin is elevated. What is the most accurate diagnosis? 58-year-old man, chest pain, ST depression on ECG. High sensitive troponin is elevated. What's the most accurate diagnosis? A, STEMI. B, NSTEMI. C, unstable angina. D, Prince metal angina. And E, chronic stable angina. Okay, I see that almost everybody is going for B. Now, doctors, in the comment section, so everyone is saying it's NSTEMI, and I think NSTEMI is the correct answer, right? Because the patient has elevated troponin with ischemic changes, but there is no ST segment elevation. So, and don't fear. A lot of candidates have contacted me, Dr. Broni, please, ECGs, we are struggling with ECGs. We are struggling with ECGs. So today, I've also included some ECGs so we can review some very important parts of the of ECG. Okay. But I have a question. Who can tell me in the comment section what is Prince metal angina? Prince metal angina, because it's something I mentioned in one of the answer options. Why didn't you choose Prince metal angina? What is Prince metal angina? What is it? Just type the answer for me. What is Prince metal angina? I know that is not a correct answer, but I'm just asking for learning purposes. What is Prince metal angina? Because we hear this, when we are preparing in group studies and we are talking with friends and all those things. What is that? What is Prince metal angina? What is Prince metal angina? And what causes it? What causes Prince metal angina? Okay, so Dr. Dinithi Sirukum says coronary artery spasms. And okay, so since you're talking about coronary artery spasms, what are some of the triggers of Prince metal angina? What are some of the triggers of Prince metal angina? Can you list 2 for me? Triggers of Prince metal angina. Coronary artery spasm. Sure, coronary artery spasm. What are triggers? Now that we've talked about what Prince metal angina is, what are some of the triggers of Prince metal angina? Prince metal angina. One of the triggers can be cold weather. One of the other triggers can be emotional stress. Another trigger of Prince metal angina can be smoking. And even some migraine medications can also do that. And when patients use recreational drugs like cocaine, like marijuana. These are all triggers of Prince metal angina. So number one, remember, Prince metal angina talks about, or it's the kind of angina which is as a result of spasms, of the coronary artery, not because the coronary artery is blocked. And because of the spasm going on, it reduces the blood flow to the heart muscle. And that is what causes the chest pain. And what are some of the triggers? Number one, cold weather. Number two, emotional stress. Number three, smoking. Number four, medications like migraine medications. Number five, patients who use recreational drugs like cocaine and marijuana. These are some of the triggers of Prince metal angina. Okay, awesome. Okay, now let's move on. I have another question. You have a 62-year-old woman who has ischemic chest pain with ST depression and normal high sensitivity troponin. What is the diagnosis? What diagnosis is most likely? 62-year-old woman. Number one, ischemic chest pain. Number two, ST depression on ECG. Number three, troponin level is normal. What's the diagnosis? And doctors, please don't forget, click and like our YouTube channel. Please click and like our YouTube channel right now. Click and subscribe to our YouTube channel right now. If you've not done that, please do that right away. Okay. So what's the correct answer? Some people are going for C, unstable angina. Some are going for E, non-cardiac chest pain. Dr. Rockefeller went for C. And the correct answer is C. C. The patient has unstable angina. Remember that when we started the class, I said that the way we look at unstable angina has changed a bit now. And remember, let's go back to this case. Why is it unstable? Why is it unstable angina? Number one, the patient has chest pain. Unstable angina, stable angina, and unstable angina, STEMI and NSTEMI all have chest pain, right? Number two, there's ST depression. Therefore, it cannot be STEMI because STEMI is ST elevation. But number three, the high sensitivity troponin is normal. Meanwhile, in NSTEMI, the high sensitivity troponin is abnormal. So let's take it from here. How will I rule out STEMI if there's no ST segment elevation? So I have a clinical case, where I'm presented with three options that I need to choose between STEMI, NSTEMI, and unstable angina. In STEMI, there's ST segment elevation on the ECG, and I'm going to show you pictures. That is how I will separate STEMI from NSTEMI and unstable angina. Now let's put that aside. So now I have unstable angina and NSTEMI. How do I differentiate between the two? In unstable angina, troponin level is normal. In NSTEMI, troponin level is elevated. So both NSTEMI and unstable angina can have ST depression. But what then goes on to separate NSTEMI from unstable angina is there elevated troponin level? That is it. Is there elevated troponin level? That's the main thing you want to see. Okay, so the correct answer is C. Let's go to another question. So Dr. Theophilus Appiah Wilson says, okay, beautiful. Okay, beautiful. That's Dr. Theophilus Appiah Wilson. Okay, so we have a 70-year-old man who presents with chest pain. His troponin is elevated, but ECG shows no ST segment elevation. Which statement is true? A, this patient has STEMI and needs thrombolysis. B, this patient has unstable angina. C, this patient has an NSTEMI. D, troponin elevation alone confirms pericarditis. And E, this finding is diagnostic of pulmonary embolism. What's the correct answer? Type in your answers. Type in your answers. Type in your answers, please. Type in your answers. Okay, I see a lot of candidates going for C, and the correct answer is C. NSTEMI, NSTEMI, NSTEMI. Okay, so what does STEMI and NSTEMI actually mean? Now that we've solved all these questions, doctors, I want to make sure, are you tracking with me? The way we are going with the class, are you tracking with me? Are you tracking with me? I want to know, yes, 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 yes. Are you tracking with me, please? Are you tracking with me? If yes, let me know. I want to know, are you tracking with me? Are you tracking with me? I really want to know, because I don't want to move fast at all. This is something a lot of candidates have reached out to me, and that is why we are having this class. Okay, good. So you're tracking. Beautiful. So let's keep on. What is STEMI and NSTEMI, and what do they actually mean? You realize that STEMI and NSTEMI are both types of myocardial infarction. That's a heart attack, right? And both require elevated troponin. And both indicate that ischemia is leading to myocardial injury. But the changes or the differences comes between, the way their ECGs present. Okay, what do I mean by that? So let's look at this table and draw the differences. In both STEMI and NSTEMI, troponin is elevated. In both STEMI and NSTEMI, troponin is elevated. And someone will say, oh, but Dr. Broni, troponin is not elevated right away. Yes. That is why in Canada and in medical practice, when a patient presents with chest pain and you do your initial troponin level and it's normal, based on the timing, don't just send the patient home. You may have to keep the patient and repeat the troponin level in 3 to 6 hours, because at times the troponin level may take time to rise. Okay, so number one, troponin level is elevated in both STEMI and NSTEMI. Number two, ECG. There's persistent ECG change which shows ST segment elevation or a new left bundle branch block in STEMI. Meanwhile, in NSTEMI, the ECG change is ST depression, T wave inversion, or the ECG may be normal. In fact, I've seen normal ECGs in a patient who has had a heart attack in my practice in the emergency room. Okay, so let's look at the difference. Troponin is elevated in both of them. Meanwhile, in unstable angina, troponin is normal. ECG, there's persistent ST segment elevation in STEMI or a new left bundle branch block. So in your board exam, these are the words you are looking for. In NSTEMI, there's ST segment depression or T wave inversion, or the ECG will be normal. What is the pathophysiology? The pathophysiology is that in STEMI, that is ST segment elevation myocardial infarction, there's complete coronary occlusion. There is complete coronary occlusion. In NSTEMI, there is partial or transient occlusion of the coronary vessel. The fourth point is that the initial management of STEMI is immediate reperfusion, which is percutaneous PCI or thrombolysis, and we've learned the contraindications for thrombolysis. Meanwhile, in NSTEMI, there's medical stabilization and early invasive strategy. So you realize that in STEMI, the cardiologist will tell you, hey, do your thrombolysis, ship the patient to the cath lab right away. In NSTEMI, the cardiologist will tell you, give your low molecular weight heparin, and then ship the patient to me, and I'm going to deal with it. That is why you have to be able to tell the difference. Okay, so let's take our time and look at some ECGs. Let's take our time and look at some ECGs. Let's take our time and look at some ECGs. Number one, This is how a STEMI looks like. And that is what people call tombstoning, right? It looks like a tombstone, right? The way a tombstone is, like, the round, the oval thing, right? That we put on tombstones, tombstoning. So this is a normal ECG on the left, which is labeled normal. And then ST segment elevation. Usually, if you want to keep it very simple in your board exam, look for elevation above two little boxes. Okay, but most of the time in a board exam, they'll make it very obvious for you to know that this is an ST segment elevation. Okay. Now, so the issue is this: there are various types of STEMI: inferior MI, anterior MI, anteroseptal, lateral, all those things. Another thing I want you to learn, and I'm going to give that as an assignment, and I want you to send me your answers by WhatsApp today. And what is that assignment? The assignment is this: list all the types of myocardial infarction and list the leads are affected. So an example of this is this: inferior MI. Which lead to be affected? It affects lead 2, lead 3, lead AVF. So if you look at the ECG very well, this is lead 2. You see that the ST segment elevation is happening in lead 2. And then you go to lead 3. You see that the ST segment elevation is happening in lead 3. And then you go to lead AVF. You look at it. Look, these cases or these things are a pattern. They happen together. So as soon as you're able to tell, okay, this particular ECG is pointing to inferior MI, boom, you are in the goal. Okay. So what I want you to do is this. So when you send me the message on WhatsApp or even under this YouTube channel, this YouTube video, just type, and I'll watch everything and I'll give you a response to every one of them. Number 1, anterior MI. Then you list the leads which are affected. Inferior MI. Then you list the leads which are affected. Anteroseptal MI. Then you list the leads which are affected. Posterior MI. You list the leads which are affected. Widowmaker MI. Widowmaker. You also list. So please, that's the assignment. Okay. I'm going to type it in the comment section. Anterior MI. Posterior MI. Posterior MI. I'm listing it in the comment section. Posterior MI. Anteroseptal. Inferior MI. And then the other assignment is tell me the vessels. Which vessels are affected? Which coronary vessels are affected? That I'm waiting. I'll be looking out for that. So tell me the leads which are affected and then the vessels. So if you pick something like inferior MI, which blood vessels in the coronary circulation are affected and which leads are affected? If you pick anterior MI, do the same thing. Let's do that for all of them. Okay. Now, if you have a patient with anterior MI, you will see that the ST segment elevation is affecting V1, V2, V3, V4. Sometimes it goes to V5 and V6. Okay, it all depends. So anterior MI, inferior MI, I've talked about some of the things in the assignment here. Okay, now I talked about the issue of a left bundle branch block. So just look at ECG patterns, and that's all you need to know. How does a left bundle branch block look like on an ECG, so that in the board exam I'll be able to deal with it. That's all you have to look at. That, it's like a rabbit's ear thing up there. That's all you need to look at, where the arrow is pointing. That shows you how a left bundle branch block looks like. So when a patient comes in, you do your troponin level, you do your ECG, and then you compare to a previous ECG the patient has had, and you start seeing some of these changes. Boom, it tells you something. The same thing. This is also a patient with MI who has a left bundle branch block. This is how it looks like. Okay, now let's go to end STEMI. Let's go to end STEMI. Remember that we said that STEMI is about ST segment elevation. End STEMI, the ECG can be normal. There can be ST segment depression. While in STEMI, there's ST segment elevation. In end STEMI, there can be ST segment depression. Okay? Yeah. Or there can also be T wave inversion. So, what are the things which point to STEMI? Please, let's do our revision. What are the ECG changes in STEMI? Please, somebody should type. And what are the ECG changes in end STEMI? Type those two answers. Let's go. What are the ECG changes in STEMI? What are the ECG changes in end STEMI? Please type your answers right away before we move on. What are the ECG changes in STEMI? What are the ECG changes in end STEMI? What are the ECG changes in end STEMI? Doctors, I'm waiting for your answers. What are the ECG changes in STEMI? What are the ECG changes in end STEMI? Okay, so remember that in STEMI we said new left bundle branch block, ST segment elevation or the tombstoning. In end STEMI, we're talking about ST segment depression, T wave inversion, or the ECG can be normal. So I'm just showing you, how these things can look on the ECG. So now that we've learned all this, let's go into a question. But before the question, doctors, please, did that make sense? That small ECG thing, left bundle branch block, ST segment elevation, and then ST segment depression and T wave inversion. Did that make sense? Did that make sense to you? Please let me know in the comment section. Did that make sense? Did that make sense? Okay. So Dr. Natasha says STEMI, ST segment elevation, sometimes Q wave, and STEMI, ST depression, or T wave inversion. Okay, beautiful. Beautiful. Okay, makes a lot of sense. So now let's deal with a question here. Let's deal with a question. Which of the following is true regarding the diagnosis of STEMI and end STEMI? A, both require ST elevation. B, STEMI requires elevated troponin only. C, both require evidence of ischemia and elevated troponin. D, end STEMI can be diagnosed without troponin elevation. And E, STEMI can occur with normal ECG. What's the correct answer? So someone says both require evidence of ischemia and elevated troponin. And Dr. Teresa Okafor says both require ST elevation. Dr. Okafor, remember that we said that one of them has ST elevation, one of them has ST depression, one of them has Q waves, one of them has, T wave inversion, one of them has new onset left bundle branch block, right? So what's the correct answer here? The correct answer is C, not A. Okay, so Dr. Asari Joseph got it. Dr. Elio, as well, Kimeza got it. So both STEMI and end STEMI require elevated troponin plus evidence of ischemia. Maybe you are confusing elevated troponin and elevated ST segment, right? STEMI, there's ST segment elevation pattern. End STEMI, there's no ST segment elevation pattern or transient ECG change. Let's move on. Another question. You have a 64-year-old man who presents with chest pain. ECG shows transient ST depression, but his initial high sensitivity troponin is normal. 3 hours later, it becomes elevated. What's the most likely diagnosis? What's the most likely diagnosis? 64-year-old man presents with chest pain. ECG shows transient ST depression, but its initial high sensitivity troponin is normal. 3 hours later, it becomes elevated. What's the most likely diagnosis? STEMI, NSTEMI, unstable angina, chronic stable angina, and pericarditis. And the correct answer is B. That's NSTEMI. NSTEMI. B. NSTEMI. 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 B. NSTEMI. Okay. Which ECG feature distinguishes STEMI from NSTEMI? Which ECG feature distinguishes STEMI from NSTEMI? A. Q waves. B. T wave inversion. C. Persistent ST elevation. D. Sinus tachycardia. And E. PR segment depression. Which ECG feature distinguishes STEMI from NSTEMI? Which ECG feature? Which ECG feature distinguishes STEMI from NSTEMI? Okay, so I see doctors going for persistent ST elevation. Persistent ST elevation, and that is the correct answer. That's the correct answer. STEMI, there's persistent ST elevation or new left bundle branch block. And STEMI, there's ST segment depression, S segment inversion, or a normal ECG or T wave inversion. Okay, why is the distinction between STEMI and NSTEMI clinically important? Why is the distinction between STEMI and NSTEMI clinically important? A, they have different risk factors. B, they have different initial management approaches. C, only STEMI causes troponin elevation. D, NSTEMI does not require treatment. And E, STEMI never needs angiography. What's the correct answer? What's the correct answer? What's the correct answer? And the correct answer is B. B. STEMI needs immediate reperfusion. NSTEMI needs medical stabilization and early invasive evaluation. The way you manage them is a bit different. So now, let's go quickly to unstable angina. But before that, I have another question. Doctors, so far, the way we've gone through this, I don't expect any STEMI, NSTEMI, unstable angina case to beat you in your board exam. So, are you tracking with me? I want to know, are you tracking with me? Before we go to unstable angina, are you tracking with me before we go to unstable angina? Okay, awesome. So unstable angina basically refers to ischemic chest pain without elevated troponin level and without persistent ST segment elevation. Okay, so ischemic chest pain, troponin level is normal, no persistent ST segment elevation. And in the era of, as I said, high sensitivity troponin, as we discussed when the class started, most patients who used to be called unstable angina are now classified as NSTEMI because the high sensitivity troponin is able to pick up, even the least amount of troponin which is released into the bloodstream. So there are various types of unstable angina, and I want us to go through them, like in terms of nomenclature, in terms of how they are named. So in your board exam, new onset angina, that is angina within less than 2 months of onset. All right. And usually that is worse if at minimal exertion or rest the patient is experiencing a chest pain. That is a very bad type of angina. Number 2, we also have what we call the rest angina, where the patient is having chest pain at rest. And usually it goes for more than 20 minutes. And there's transient ST changes. Transient ST changes. And this is a very high risk feature that you need to pay attention to. And then we also have early post-MI angina. What is that? Early post-MI angina is pain within 48 hours after myocardial infarction. So you have a patient who has had myocardial infarction. The patient has been managed in the cath lab, and then within 48 hours, the patient starts experiencing new onset chest pain. When you see a case of early post-MI angina, it indicates that there's persistent thrombus or multi-vessel disease. So that means that the thrombus which was causing the initial chest pain is still persistent, or it could be that other vessels have been affected and it was not picked up initially. And then we also have post-revascularization angina, where the patient experiences chest pain after PCI or after CABG. Okay, and it could be as a result of the blood vessel getting clogged again due to restenosis, or the graft which was put there has failed, or there's a new lesion. And we also have periprocedural angina, which is the patient has PCI, and within 48 hours of having the PCI, the patient is having the chest pain. And then we have late angina, which is happening more than 30 days after PCI. Okay, and it's often as a result of restenosis or progressive native disease. Okay. So now, what are the diagnostic clues? This one, just so that you can be able to pick it on a board exam. Just so that you can be able to pick it on a board exam. Rest or minimal exertion angina plus transient ST changes, that's a very high risk thing. You want to be very careful about that. Number 2, early post-MI angina. If you have a patient who has had myocardial infarction, the patient was taken to the cath lab, patient has come out, and within 48 hours, the patient is having chest pain again, that means there's a high risk of reinfarction and a high risk of death if not revascularized. If they don't, go back again to do the procedure, there's a high risk of reinfarction and high risk of death. And what about if it's occurring after a CABG, where the patient is having recurrent angina? That means that this patient must be sent to the cath lab urgently, because that can be disastrous. And what about post-PCI? When the patient has had the percutaneous procedure. Now, it helps to differentiate ischemic from non-ischemic chest pain. Okay. And with the ischemic chest pain, you realize that there's ST segment elevation, there's increased troponin. But with non-ischemic chest pain, you realize that there's localized pain and no ECG or troponin changes when you do them. Okay. So now, I have a question for pain. 24 hours after a myocardial infarction. What does this most likely indicate? Pain 24 hours after a myocardial infarction. What does this most likely indicate? A, pericarditis. B, reinfarction from persistent thrombus or multivessel disease. C, post-MI syndrome. D, non-cardiac chest pain. E, anxiety. What's the correct answer? What's the correct answer? Patient develops chest pain 24 hours after myocardial infarction. What does this most likely indicate? A, pericarditis. B, reinfarction from persistent thrombus or multivessel disease. C, post-MI syndrome. D, non-cardiac chest pain. And E, anxiety. I see a lot of candidates. Dr. Rockefeller is torn between B and C. So first he goes for B. And then after that, he says, or it could be C. Or it could be C. Okay. So the correct answer then comes as B. So Dr. Rockefeller, listen to your gut in your board exam, right? When you've gone for something first, stick to it. Stick to it. Stick to it. Okay. So early post-MI angina is persistent intracoronary thrombus or residual ischemia, which is a very high risk thing. Okay. Now, after PCI, a patient reports sharp, localized pleuritic chest pain without ECG changes or troponin rise. What's the most likely cause? After PCI, a patient reports sharp, localized pleuritic chest pain without ECG changes or troponin elevation. What is the most likely cause? A, ischemic stent thrombosis. B, overexpansion of the stent. C, a new aortic or a new dissection. D, side branch occlusion. And E, myocarditis. What's the correct answer? Remember that it is localized, it is pleuritic. That means the patient experiences the pain when he or she breathes. And there are no ECG changes or troponin elevation. So can you say it is an ischemic stent thrombosis? I don't think so. The correct answer would rather be B, because ischemic stent thrombosis, myocarditis, side branch occlusion, new dissection, all of them will lead to troponin elevation. The only one which will not lead to troponin elevation is overexpansion of the stent, right? You put a stent in to keep the blood vessel from getting filled up by clot again, or you put a stent in to take away the old clot, and the patient is having pleuritic chest pain. Pleuritic chest pain. It's as a result of overexpansion of the stent. Why? Non-ischemic pain post-PCI, it could be because the stent is expanding, and usually it resolves within days. And if you want to master that particular diagnosis, remember that when you do your troponin levels, the troponin levels will be normal. There will be no further ECG changes. That tells you that there's something happening in the stent, and reassure the patient that the pain will resolve. Now, I have another question. Which group is most likely to have non-ST segment elevation, acute coronary syndrome without significant coronary disease or angiography? Which group is most likely to have non-ST segment elevation, acute coronary syndrome without significant coronary disease or angiography? A, older men with diabetes. B, younger women without diabetes or smoking. C, elderly smokers with hypertension. D, men with prior myocardial infarction. And E, patients with multivessel atherosclerosis. Which group is most likely to have non-ST elevation acute coronary syndrome without significant coronary disease or angiography? Dr. Rockefeller, again, you are saying A or B. Please be bold, be bold. Stick your neck out. Stick your neck out, please. Okay, stick your neck out. So, Dr. Rockefeller, I'm not going to take your answer. Get me a different answer. Dr. Sari Joseph will go for A. Dr. Valerie will go for A. Dr. Elo Kimezi will go for A. Dr. Ino Akpala says she go for C. Remember, which group is most likely to have NSTEMI, acute coronary syndrome, without significant coronary disease or angiography? So a lot of people are going for A and C. And the correct answer is rather B. I think only Dr. Sari Joseph got that right. So there are two studies which were done. We call it the Crusade study and the Pursuit study. It shows that younger women, okay? It shows that younger women, okay? The Crusade study and the Pursuit study says younger women, more than men, often they are non-smokers and they have minimal disease, but then they can present with myocardial ischemia. You remember the Pursuit study and the Crusade study. So remember, let me go back to the question again. You are looking at a group of people who will have NSTEMI, no ST segment elevation, acute coronary syndrome, and they don't have any significant coronary disease, no angiography. Well, older men with diabetes can have significant coronary disease. Elder smokers with hypertension can have significant coronary disease. Men with prior MI, well, it is because they had significant coronary disease. That's why they had the MI, right? Patients with multivessel atherosclerosis, come on. So all these are staring in your face, risk factors, right? The only one who does not likely have significant coronary disease is that young woman who is walking on the street who plays volleyball or tennis, okay? Or people who smoke. Okay. So, doctors, have a question. We're about to go into our active recall. How has today's class been? I want to know. How has today's class been so far? How has the class been so far? How has the class been so far? I need some input before we go into our active recall. How has the class been so far? How has the class been so far? And I'll be taking suggestions from you. How can we improve these YouTube classes? Right? Just tell me. Okay. Someone says awesome. Someone says awesome. Someone says I got it. Dr. Salihu says he got it. Dr. Victor Williams says it's been very nice. Sure. Insightful. Fantastic. Great. Okay, good. So again, what can we do to improve these live classes? Are you okay with the way we're able to pick one concept and go deep into it? Do you want us to reduce the number of questions we do? You know? Okay, so Dr. Rockefeller says you need to come on some Thursdays. I see. Okay. I will look into it. My schedule is a bit, funny for now, but we can look into it and occasionally maybe add a weekday as well. Okay, good. Okay, very good, understandable, perfect. Okay, so now let's get into active recall. But before active recall, do you know that this week QE1 results were released? This week, MCCQE1 results were released. MCCQE1 results were released. Then it's been awesome. So someone sent me a message, Dr. Broni passed. Then you know what? I was so excited that I sent the person emoji of mothers who are just sliding on. It was awesome. Like this week was great, right? Another one says, good afternoon, Dr. Broni. This is to inform you that I passed my MCQ1. I want to especially thank you and the MedCognito team for your assistance regarding the excellent tutoring, preparation, revision, resources in the portal. May the Almighty God continue to bless and reward you for all your labor of love. Beautiful. Okay. Another one says, the other one just sent me. So it was the August exam, and they just released the results, right? So those who took the exam in August, so September, October, they just released their results. Because now it's only MCQE1, they don't take long time to release the results. And then someone from Ghana sent a message. Hello, Dr. Broni. I passed. First attempt. Thank you so much. Your help made me pass it in one go. And I didn't do it alone. We have wonderful teachers, Dr. Renequia, Dr. Prosper, Dr. Emmanuel, all these, Dr. Edwin, all these doctors help to make this a reality. And the interesting thing is that all the doctors are also practicing in the Canadian healthcare system. Some are in Ontario, some are in BC, some are in Alberta. So it's awesome. Okay. Another doctor says, good evening, Dr. Broni. My Q1 results are in and I passed. I'm so grateful to you and MedCognito. Your materials helped me organize myself and build the confidence I needed for this exam. By the way, doctors, do you know that? And we also got some good news from Cuba. One of our candidates is from Cuba. So that's why I put the Cuba flag there. Hi, Dr. Broni, I passed. And then I called the person. We had like a 3-minute talk. We prayed together. It was awesome. Excited. I got opportunity to talk to the family, the wife, their child. It's awesome. So doctors, what I want you to understand is that this is also for you. We are here. MedCognito is here to serve you. Okay. And did you also know that we are running a promo right now? So if you've not received an email in your portal, we are running a promo. Instead of you paying $420 every month for 6 months, which will come up to 2,520. We are running a promo for a one-time payment of 1,997. So you are saving almost $600. Or if you want to make just two-time payments, $1,050 for 2 months, and you get access to 6 months of intense tutoring. Everything is on your laptop. Question bank, med bullets, med drills, mocks at your own convenience, and then discounted mocks every 2 weeks. So I want you to know, if you want to take advantage of this, after this class, just give me a shout right now. Please, after the class, just call me. Call me on my WhatsApp, +1 306 891 5649. +1 306 891 5649. Now, let's get into our active recall. First question: what are the 3 traditional types of acute coronary syndrome? Please, this one, type your answers, bam, 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 and let's go. What are the 3 types of acute coronary syndrome? What are the 3 traditional types of acute coronary syndrome? What are the 3 traditional types of acute coronary syndrome? Three traditional types of acute coronary syndrome. So, STEMI, NSTEMI, unstable angina. Somebody just got it. STEMI, NSTEMI, unstable angina. Let's go to the next question then, since a lot of people are getting it. Which biomarker redefined acute coronary syndrome classification? Which biomarker redefined acute coronary syndrome classification? Which biomarker? Which biomarker redefined acute coronary syndrome classification? Beautiful. Troponin level. So high sensitivity troponin. Beautiful. Beautiful. I like that. Let's go. What do STEMI and NSTEMI have in common? What do STEMI and NSTEMI have in common? What do STEMI and NSTEMI have in common? Tell me something, doctors. What do STEMI and NSTEMI have in common? Dr. Joanna De Cruz says both have elevated troponin and evidence of ischemia. Beautiful. Both have elevated troponin and evidence of ischemia. So, okay. So now that you talked about this, what's the difference between STEMI and NSTEMI? Now we looked at what makes them similar. Now let's talk about what separates them. STEMI and NSTEMI. What's the difference? Tell me something. Tell me something. Tell me something. For your board exam, what's the difference between STEMI and NSTEMI? STEMI and NSTEMI. Tell me something. What's the difference between STEMI and NSTEMI? Since you said both of them will have elevated troponin level, STEMI and NSTEMI, what's the difference? What's the difference? What's the difference? What's the difference? Doctors, tell me something. Tell me something. STEMI and NSTEMI, what's the difference? STEMI and NSTEMI, what's the difference? Remember that in STEMI, there's ST segment elevation. In NSTEMI, there's ST segment depression. In STEMI, there's new left bundle branch block. In NSTEMI, there's T-wave inversion. So it all comes with the ECG changes. I don't want you to miss this in the MCQE1. Okay. Next question. How long can it take for troponin to rise after chest pain onset? How long can it take for troponin levels to rise after chest pain onset? How long can it take for troponin to rise after chest pain onset? Okay, I see 3 to 6 hours. Some are saying 4 to 6 hours. usually up to 3 hours. So 3 hours and above, right? 3 hours and above. So doctors, please, I beg you, especially those who are going into the practice ready assessment, please, I know that for many jurisdictions, it's not something we do, but in Canada, now it is, say, 12:04 in Ontario. The patient comes to you, please. The patient comes to you in the ER. And because when you're doing your practice ready assessment, you'll be doing ER as well, right? Most of the time, you have to do some ER, rural ER as well. So if you have a patient who comes to you now, it's 12 o'clock in your ER, and the patient came now at 12, and the patient stated that I started having chest pain at 11 o'clock. And then your initial troponin level was normal. This is like a 65-year-old male who has diabetes, who smokes. Doctors, when will you do your next? What's your next best step? Will you let the patient go home? Or what else will you do? Will you let the patient go home? Or what else will you do? I want to know. You're in rural Ontario. It's currently 12:05. Patient started experiencing chest pain at 11 o'clock. Patient is 65 years old, diabetes, smokes, has a family history of myocardial infarction. What's your next best step? A, let the patient go home because troponin levels are normal. ECG is fine. B, keep the patient and repeat ECG by 3 o'clock p.m. C, give the patient PPI and reassure the patient is just gastroesophageal reflux disease. What will you do? What will you do? Good. You want to recheck the troponin around the 3-hour mark. You want to do that, please. For medical legal reasons and even to help the patient himself or herself, please do that. Okay? Okay, good. How soon after MI can early post-MI angina occur? Good. Dr. Teresa, beautiful. Says admit and repeat. Good. Okay. So, how soon after MI can early post-MI angina occur? How soon after MI can early post-MI angina occur? How soon after MI can early post-MI angina occur? Dr. Joanna De Cruz says within 48 hours, and that is the correct answer. My goodness, this lady is paying attention. You want to see one of the most serious students in MedCognito? That's Dr. Joanna De Cruz. It's awesome, whenever she reaches out. Great. And doctors, that is what we do at MedCognito. Our candidates have access to it. And that's why I've gotten to know Dr. Sari so well, Dr. Rockefeller. In fact, we spoke this week. This gentleman, this guy, I've put his answer on the page. If you want to reach out, please reach out. Let's have a conversation. You call me. I can't pick. No worries. I will call back. Maybe I'm in the ER. Maybe I'm seeing a patient. But definitely, I'll call you back. Okay? Good. Next question. What does recurrent angina after cabbage indicate? You have a patient who has had cabbage and the patient is having recurrent angina. In your board exam, what does that indicate? Recurrent angina in a patient who has had cabbage, what does that indicate? Recurrent angina in a patient who has had cabbage, what does that indicate? Recurrent angina in a patient who has had cabbage, what does that indicate? Well, it means that there's a technical graft problem, right? And the patient needs urgent catheterization. Patient needs urgent catheterization. Oh my goodness, I shouldn't have put the answer here. Who most often presents with acute coronary syndrome but normal coronaries? Who most often presents with acute coronary syndrome but normal coronaries? It's young people, females, non-diabetic, and non-smokers. Young patients, female, non-diabetic, and non-smokers. Let me say it again. Young people, female, non-diabetic, and non-smokers. These are the people who usually present with acute coronary syndrome but normal coronary vessels. Okay, so doctors, this is it. It's been awesome today. I've really enjoyed the class. You know, it's been awesome. I've really enjoyed your participation as well. Please, that's my phone number. That's me. If you get a message from this number, it is coming from me. I know in recent times, some scammers have tried to scam people, but please, this is my phone number, +1 3068915 5649 +1 3068915 5649. Pick this number, call me, let's get a ball rolling. Okay, take advantage of the promo. Only $1,097 as compared to paying $2,520. Okay, we are here to support you, we are here to guide you. Get in touch and let's study together, and let's go out and ace the exam. Doctors, please, thank you so much. It was wonderful spending your Sunday morning with me. I really appreciate you and thank you. Please, let's make preparing for the QE1 something very simple. Thank you. And because now I live close to Quebec, I'll say au revoir, au revoir, au revoir. See you. Enjoy your day.